Okay. Your case list look familiar?
This is mine.
Okay. Okay, doctor, so let's go to case number 13.
Okay.
So this is a patient that is a type 2 diabetic, is that correct?
Correct.
So tell me, when she comes in for her first prenatal visit, what are some of the things that you would counsel her on, and what are some of the things that you would tell her are important?
So a patient who comes in for their first prenatal visit with type 2 diabetes, so first I always want to counsel them on general prenatal items, to stop smoking, eat a healthy lifestyle, stop alcohol use, and then I like to kind of get into the specifics of the diabetes. And that includes the importance of blood glucose control, to optimize fetal and maternal status, as well as her increased risk in pregnancy because she has type 2 diabetes.
Okay, what are some of the increased risks specific to diabetes?
So some of those increased risks, so poorly controlled diabetic patients with diabetes do have increased risk of fetal malformations. They are also more likely to develop preeclampsia, go into DKA, more likely than to go into DKA outside of pregnancy, and have preterm delivery.
Can you think of anything else?
They are also at an increased risk of fetal macrosomia, shoulder dystocia, and cesarean delivery.
I see. So what would be your management plan for a patient like this? And would you have a blood sugar goal for them and a hemoglobin A1C goal for them?
Yes, absolutely. So I would certainly have our patients with type 2 diabetes be seen in the clinic a little more frequently. I'd like them to meet with our diabetic educator. And traditionally, I co-manage these patients with a maternal fetal medicine physician. In terms of my blood sugar goals, A1C less than 6.5 is ideal. Ideally less than 6, but 6.5 is kind of like our baseline goal, but ideally less than 6 for an A1C. And in terms of blood sugar checks, I would be having her check her blood sugar PC, so 1 to 2 hours after meals and fastings. Those goals would be, if I'm going to do a 2-hour check, less than 120 and a fasting of less than 95.
Okay, so let's say now this patient is at 38 and 2 days, correct?
Mm-hmm.
Was this somebody that you induced, or was it somebody that came in spontaneous labor?
This patient came in spontaneous labor.
So if you did not come in spontaneous labor, when would you have induced this patient?
So typically, recommendations by ACOG for type 2 diabetics.
Doctor, I don't want ACOG's recommendations. When would you have induced her?
I would have induced her at 39 to 40 weeks if she was well controlled.
On medications, you would have waited till 40 weeks?
39 and so by 4 I mean 39 and 0 to 39 and 6 would be acceptable.
Okay. Are there instances where you would deliver at 37 or 38 weeks for a type 2 diabetic?
If they are poorly controlled, so my definition of that would be an A1C of 7 or greater, you can consider delivering earlier.
I see. Is there a certain weight that you would actually offer them a C-section?
For diabetics, if they have an estimated fetal weight of over 4,500 grams, they do offer them a C-section.
Okay, so it looks like this patient had a category 2 tracing, correct?
Correct.
Can you please define a category 1 tracing for me?
So a category 1 tracing would be moderate variability, a baseline between 110 to 160, ACT cells either You do not have to have ACT cells present, so plus or minus ACT cells. Early D cells are acceptable, but they can have no variable or late decelerations.
Okay, doctor. So let's assume this patient now was at 7 centimeters and she had a category 2 tracing. Please walk me through how you would manage this.
So for if I see a category 2 tracing at 7 centimeters, then I'm going to first assess, go and assess the patient, check her vital signs, see what she has anesthesia. I perform intrauterine resuscitation, so I will make sure the nurse and I are repositioning the patient, preferably a left lateral, giving an IV.
Let's assume all of these measures have not been successful, and the patient's main problem in her category 2 tracing is recurrent deep variable decelerations. What would you consider doing at that point in time?
So at that time, I would consider doing an amnio infusion if deep variables are the main concern.
Okay, can you please walk me through the steps of how you would do an amnio infusion?
So for an amnio infusion, first I examine the patient. So I check the patient and I have a small catheter that I then place, that I kind of slide over my hands while checking the patient.
Okay, so you've placed the catheter. What type of fluid do you put and how much fluid do you put in?
So we start with a bolus of 200 cc's of LR, and then they do a maintenance of.
Okay, time.
Okay.
How did you feel you did?
I think I did okay, but it was actually really hard, and I often have to say all that stuff out loud.
Correct. So I would advise you, whenever somebody asks you what are the complications of, right?
Mhm.
Always say there are fetal complications and maternal complications. Not that you got them wrong, but
Okay.
it's much more elegant, much more nicer when you say there are fetal complications and there are maternal complications. And then if you start with your fetal complications and you say, I'm giving you an example, right? Increased risk of miscarriage,
Okay.
structural abnormalities, increased risk of IUFD, growth abnormalities. See how it's just in a system,
Yes.
right? And then when you say maternal complications, then you can say preeclampsia, so forth. But now it makes the examiner know that you have a system of how you get these complications, right? You started maternal, fetal, you started from an earlier gestational age and you moved on. Chances are they're going to stop you. Chances are I'm not going to have to prompt you to say IUFD, right? Because you have a system of walking through this. And then I'm going to tell you, it's very simple. Any condition that you put serial growth ultrasounds and antenatal testing, why are you doing that?
To prevent stillbirth.
And because they have probably growth abnormalities. Okay, I would urge you to look at the timing of delivery for diabetes. It is, unless they're diet controlled and they're gestational, I do not recall here. Why don't we do this? Just make sure that I don't give you anything wrong, right? I do not recall that you go to 40 weeks if they're on insulin.
You know, you're absolutely right. They don't go to 40 weeks. It's like 30. They can max go to 36 and 6, 39 and 6.
30, from my recollection, it's 39. It's 36 to 39, depending on your glucose control. But since we have a nice little audience, I don't want to. So pregestational diabetes, well controlled, is 39 and 6. Not well controlled, then you can change that all the way from 36 to 30. The only thing that I recall that you can actually do to 40 weeks is gestational diabetics. If I'm not, yep, there it is. Gestational diabetics, well controlled on diet. That's the only way you can go to 40 and 6. Okay, so just make sure that this is your friend on the exam. Just make sure that this is something that all of you know very, very, very well. All right?
Okay.
Sounds good. I'm sorry that you always get me, but you can see I've got a variety of questions of how to ask you and all that sort of stuff. I think you did pretty well in the category 2. And did you just notice how I just threw category 1 at you out of nowhere?
Yes.
Right? You're like, okay, category 2. He's going to ask me what category 2 is. And I just said, what's category 1? right?
Yeah. Thank you
So unfortunately, that's just the exam sometimes goes. You'll sit there and they'll go, all right, what's this? And you're like, where did this come from, right? So you've just got to be prepared to kind of take a deep breath and go, okay, thank you very much. Let's go ahead and answer what they asked me. All right. Thank you very much. If you want to, we'll mute you. I'm sorry, I hate to do that, but I will mute you now in a minute. Okay. All right, let's go back to our nice, wonderful list, right? And see if you can see your name. Okay, so I know that some of you may have joined a little bit later on, but anybody, Dr. Brar is there? Okay. Let's see if there's anybody else. Dr. Nelson is there, but it's down in the list. All right. Dr. Brar, I also quizzed you before. Are you good with me quizzing you again?
Yes, sir.
Okay. I just want to make sure that we're all in the agreement. But like I said, I've done this for a very, very long time. Trust me, no exam is going to be looking the same, right? And I'm going to try something interesting here, and we'll see how you do.
Lovely.
Okay. Okay. So doctor, let's go to case number 11.
Okay.
So you have a patient here that is obese, right?
Mm-hmm.
Can you please tell me how you counseled this patient when she first came to you? What would be some of the complications that she would encounter?
Yeah, so in patients that have obesity, I counsel them both on maternal and fetal complications during the pregnancy. From a fetal complication standpoint, I discussed with her the increased risk of miscarriage, the increased risk of congenital anomalies, the increased risk of having an incomplete anatomy ultrasound where there's an inability to pick up those same congenital anomalies. We talk about the increased risk of macrosomia, and the increased risk of stillbirth. From a maternal standpoint, I talked to her about her increased risk of developing gestational diabetes, preeclampsia, increased risk of having dysfunctional labor with concomitant need for cesarean section, and then an increased risk of wound infection or wound disruption after delivery as well.
I see. So you said that they're at an increased risk of diabetes. Is that correct?
That is correct.
So do you manage those pregnancies any differently than other pregnancies because they're at an increased risk?
Yes, those are pregnancies that I generally will get a early 1 hour glucose challenge test at their
So let's
first.
assume that your 1 hour glucola came back in the first trimester at 150. Would you
Okay.
consider that normal or abnormal?
If it came back 150, I would consider that abnormal, and then I would counsel her to perform a 3 hour glucose test.
Okay. Just for clarity, let's assume that you did this at 16 weeks of gestation. All
Okay.
right?
Mhm.
And the 3 hour glucola came back absolutely normal.
Okay.
Are you going to perform screening again at any time in pregnancy? And if so, how are you going to screen this patient?
Yes, I would repeat screening between 24 to 28 weeks, and I would start screening with the 3 hour at that time.
So you would forgo the 1 hour glucola.
Correct.
Okay. Now, let's assume that you did a 1 hour glucola again for whatever reasons. Is there a specific number where you would not do a 3 hour glucola?
Yes, if the 1 hour glucola was greater than 200, then I would manage her as a presumptive gestational diabetic.
I see. So let's assume that you diagnose this gestational diabetes with her. Tell me, what are you going to do as a first step in management?
So as a first step in management, I would manage her conservatively. I would talk to her about the importance of proper diet, have her meet with the nutritionist in my office, talk to her about exercise, and then I would have her, after implementing those two behavioral modifications, I would have her panel her blood sugars, fasting, as well as 3 times a day after each meal, and then come see me the next week in the office to see if we were able to get some benefit from those initial interventions.
What target blood sugar would you give her?
So the target blood sugar I would give her would be a fasting of less than 95, and a 1 hour postprandial of less than 140. And that's what that's what I
So
do.
you use a 1 hour postprandial, not a 2 hour?
Yeah, that's just what we do at my institution, but I am aware that you can use a 2 hour of less than 120 as a goal as well.
I see. Okay, let's go to case number 12.
Okay.
Is this somebody in your office that you would offer aspirin to?
This is someone that I would offer aspirin to.
So tell me, what are some of the other indications for giving a patient aspirin?
So I give patients aspirin if they have more than one high risk factor, and I'm sorry, one or more high risk factor, or 2 or more moderate risk factors. The high risk factors that I would consider would include a history of preeclampsia and a prior pregnancy, a patient with chronic hypertension, pre-gestational diabetes, kidney disease, lupus, or multifetal gestation.
Okay, let's assume that your patient had lupus.
Uh-huh.
Is there anything in the pregnancy that, or specifically to the baby, that you would be worried about with patients with lupus? And is there any blood test that you can do to determine that risk for the baby?
So one of the things that's particular to lupus that I would be thinking of would be getting a anti-SSA, SSB antibody, and if positive, that would put the fetus at an increased risk of developing congenital heart block. Would you like me to discuss?
Would you consider putting the patient on Plaquenil? And do you think it is safe to put somebody with lupus on Plaquenil?
I do. I would continue the patient on Plaquenil if she came into the pregnancy on Plaquenil. If she wasn't on Plaquenil, then I would discuss with my maternal fetal medicine colleagues, as well as the patient's rheumatologist, about the the opportunity to put her on that medication. But that is something that that I would generally advocate for in a pregnant woman with lupus.
Okay, let's go to case number 17.
Sounds good.
Okay, so tell me, how did you diagnose trichomonas in this patient?
Yeah, so this is a woman who came in at 39 weeks and 5 days, and she came in for a elective induction of labor. She was complaining of some vaginal discharge, and so on exam, she was noted to have some frothy appearing vaginal discharge on speculum exam. We did send her for a vaginitis panel, which came back positive for trick. And so she was.
So let's assume you did not have the ability to do a vaginosis panel.
Okay.
What would you anticipate to see under the microscope if you looked with trichomonas?
So in a patient with trichomonas, I would expect to see motile flagellanoids.
What would be your top choice of treatment for this patient?
So my top choice for treating her would be giving her metronidazole 500 milligrams twice a day for 7 days.
Okay, so then the patient asks you and tells you, doctor, what is the most common STD in the United States?
I would say that would be. I would tell her that would be. Does that include HPV? I would say HPV or chlamydia, depending on whether one considers HPV a sexually transmitted infection.
Do you consider HPV as an STD?
I would say yes.
Okay. All right, time. Don't hesitate. Okay, but you actually didn't hesitate at all, except in this little thing. HPV, right? HPV, sure, it's an STD, right?
Yeah.
It is the most common STD in the United States, right?
Yes.
How would I make trichomonas the most common? If I asked you, what is the most common protozoan, then you could say trichomonas. But the treatment is correct, the diagnosis is correct, flagellated motile epithelium is correct. I love the fact that you actually went and said fetal complications, maternal complications. You went from that, you went to this, right? And you did stick to a lot of things about my practice. Okay, so for example, you didn't say, I prompted you, I asked you, but you didn't flat out say, and you can do a 1 hour and you can do a 2 hour, because it's true, you can do a 1 hour postprandial, you can do a 2 hour postprandial, but what did you tell me? Your management, right?
Mhm.
Because what is the exam? And I keep telling people, what is the exam? The exam tests your management, not what ACOG tells you. Let me rephrase that. What ACOG tells you, but not if like you follow the ACOG guidelines, but you pick from that guideline what you're going to give. So you don't tell the examiner you can give labetalol, hydralazine, and what are you going to give? Hydralazine 5 milligrams, right? I actually think that you're very calm, very collected. You did very well. You answered the questions, in my opinion, very, very nicely. I think you did an extremely good job, right?
Thank
Any questions that you have for me? Anything that you felt was out of the ordinary?
No, thank you so much.
Okay, well done. Take care. All right. All right. Dr. Ibizo, your name was first. Are you good with us examining you? All right. I unmuted you.
Hello,
Can you hear me?
I can hear you. Can you hear me?
Yes, I'm sorry I did not see you at the very beginning, so I apologize if I missed you by mistake, but I'm glad
No,
we.
you didn't. No, you didn't. I wasn't on in the beginning. I'm on call right now, running around trying to catch some babies. But I think I have a little bit of time. I'm
Well, if you
waiting on
need to
one, but
leave,
she's not
just let
ready.
me know.
Okay.
But we'll try and quiz you. We'll try and quiz you as best as we can.
Okay.
All right. Let's see. I think I saw your case list. There it is. Is this your case list?
Let me see. Make it bigger. I can see. Yes.
Okay. All right. Let us go to case number 2.
Okay.
All right. So, doctor, this is a patient that came to you at 22 weeks and 5 days, correct?
Correct.
So please tell me how you counseled this patient.
Actually, this patient came before 22 weeks. Actually, she ended
So
up
tell me her
delivering.
story.
So she is. I don't remember her age now. Okay. I don't remember. Oh, 34-year-old. She was a I believe she was a G5P2, and came in ruptured at 20 weeks. But she went to an outside hospital and they told her she was ruptured. And they told her, again, kind of talked to her about her options and that she was pre-viable, so there's probably nothing you can do, or they could possibly induce her and she'll probably deliver. She didn't like that answer, so she left and went to her primary OB's office, who then also talked with her and admitted her to the hospital because she wanted everything done for this pregnancy. And so we had to consult the MFM and have a talk with her, as well as the NICU team have a talk with her because she was so early. but
I
she
see.
wanted everything done.
So, what do you call it? What would you say are some of the risks that are involved in pre-viable PPROM? So what are some of the things that you talk to the patient about?
We talked to her about infection for sure, since she'll be ruptured for a long time. We talked about abruption as well. And for fetal, we kind of talked a little bit about it, that if the fetus did survive, there are possibly a lot of complications once the baby is born, if it were to survive till 24 weeks, since she's been ruptured for so long. But that's why we had the NICU come talk to her. But the main two were the infection and also abruption.
So doctor, let's say this patient now made it to 28 weeks.
Yes.
And the baby was born at 28 weeks and it couldn't breathe.
Yes. Oh, yes. And lung immaturity. Yes.
Okay, what
Fetal
would
lung immaturity.
be your explanation for a 28-week not able to breathe?
The explanation would be that there was low fluid or no fluid, and the fluid is one of the things that helps the lungs to mature.
Okay, in your institution or in your practice, what is the earliest gestational age / EFW that you would offer an intervention for a patient?
In this institution, it changes based off the fetal weight, and the fetal weight was 450 grams. Sometimes it also depends on who the NICU attending is.
Stop here.
Oh, sorry.
They don't want to hear that.
Okay.
And they don't know what you do in your hospital.
True.
So pick something and say this is where you resuscitate.
Okay, 450 grams.
So 22 week, whatever it is, like our hospital, they will resuscitate. I'm just giving you an example. You can say,
Okay.
in general, we resuscitate at 23 weeks and 500 grams. And then anything below 23 weeks and 500 grams, it's on an individual basis after counseling the patient. Thank you.
Okay. Okay.
See how it's like, and I'm sorry to stop you, but what you've got to remember is ABOG does not know. The examiner does not know what you do, and they don't want to know that you have a different individual that does this. Give them one answer and move on if it's logical, right?
Okay.
The same thing applies if you have a postpartum hemorrhage and I tell you what's your postpartum hemorrhage protocol. They don't know what you have.
Correct.
Pick the one that you like and give it to them.
Okay.
Right? Now, again, remember, whenever you counsel, and I didn't mean to, but whenever you counsel about pre-viable PPROM, you've got to talk to and say there are maternal complications associated with pre-viable PPROM, mainly maternal infection, possible sepsis, right? These are things you have to go. And then what are some of the fetal complications? The patient can deliver early, and most of them deliver within 1 week. There's an increased risk of cord prolapse, IUFD, contractures, lung hypoplasia. See how I've given them all of these things that you need to talk about.
Yeah.
Because you've got to tell them, what am I really worried about when somebody ruptures this early?
Correct.
The mother is going to get infected and get sick and septic and really sick, right? Because that's still something on my horizon, right? On the flip side, is this baby going to survive the same way as somebody that is not ruptured? Do I have additional complications? And the answer is yes, correct?
Correct.
All right, sounds good. Did you find that little discussion helpful?
Yes.
All right.
Yes.
So
Thank you.
let's move on to one of your other cases. Remember, the exam doesn't want to hear there's differences of my partner did it this way, my partner doesn't do it that way. They just want to know how you manage them.
Okay.
So doctor, let's go to case number 9.
Let's see. Yes.
Right, and I'm actually happy that you're actually on call. You know why?
Why?
Because you're a little bit distracted. So if you can answer when you're a little bit distracted, then that would be very similar to the pressure of the exam.
Okay.
All right. So doctor, let's go to case number 9.
Yes.
And it says here, history of pulmonary embolism. Is that
Yes.
correct?
Yes.
Let's assume that you saw this patient for preconception counseling with a history of pulmonary embolism, are there any additional labs that you would like to do, assuming that whoever saw this patient did absolutely no lab work for the pulmonary embolism?
Yes. So, hold on. Okay, I'm not ready yet. Okay, yes. I would get some labs that we normally check for anybody who is has a history of DVT or pulmonary embolism, such as the protein C, protein S. You can get a APA or ANA, factor 5, the thrombin, antithrombin 3, and I believe that's it.
So, doctor, you would not be interested in knowing if she has antiphospholipid syndrome?
Yes, APA, that's the last one I was thinking about.
Okay, so let's assume now that she is pregnant, and let's assume that this patient has a factor 5 Leiden deficiency.
Okay.
Would you offer this patient anticoagulation during pregnancy?
Yes, given her history of the pulmonary embolism as well.
Okay. And would you give this patient anticoagulation postpartum as well?
Yes, for at
So
least 6 weeks postpartum.
in this particular patient, was she on any anticoagulation?
She was.
Okay. Do you remember what she was on?
She was on Lovenox, and then she was switched to heparin at 36 weeks.
Okay, what would be your dose to give, assuming that this patient has no thrombophilia positivity or antiphospholipid syndrome? What would be the dose of anticoagulation that you would give this patient?
She was on this patient. She was on 40 milligrams of the Lovenox daily, and then at 36 weeks she was switched to heparin 5,000 units BID.
All right, let's go to case number 11.
Okay.
So this is a patient who was in labor with a history of herpes, correct?
Correct.
So tell me why you did the speculum exam.
We were checking to see if she had any lesions, herpetic lesions, ulcers
Okay.
on her
Now,
cervix as well as her genita.
with the knowledge of the fact that she has a history of herpes, is there anything that you would do differently during her pregnancy?
Yes, we did prophylactic treatment at 36 weeks to give her Valtrex.
Valtrex? What dose?
Yes, we gave her 500 BID
Okay. For how long?
daily until she came into labor. It was for the remainder of the pregnancy.
Okay, doctor, let's go to case number 13. So this is a lady with twin gestation, is that correct?
Correct.
Now, I see here that she has a prior C-section, but
Correct.
let's assume that she did not. Do you personally deliver twins vaginally?
Yes,
Under what circumstances?
as long as the fetal A is vertex.
So please walk me through the steps of how you would do a breech extraction.
Okay. Breech extraction. I would for the second twin, I would of course do an exam, and then find the fetal feet. Make sure I have both of them in my hand, like between my knuckles, and then have the
So,
patient.
doctor, before you do that breech extraction, are there any
Yes.
precautions that you would take or certain personnel that you would like in the room?
Yes, everyone will be in the room because we'll be in the operating room. So I'm assuming with twin A, we've already had everybody, the NICU, as well as anesthesia, as well as to the charge nurse, and then another OB around on the floor at the very least.
I see. So let's assume now that the baby's head did not come out or got stuck.
If she has adequate anesthesia, I could perform a Dershen's incision to help to release
Perform that on a fully dilated cervix.
if the head is entrapped,
But what would you cut?
the cervix.
But she's
But
fully
I guess
dilated.
it would be fully dilated. That's true. I don't know.
All right, time.
Okay.
How did you think you did?
Horribly. 'Cause
I'm
this was
gonna
my
say
first
that-
time and I'm watching out for a patient.
Yes, that's what I'm going to say. I think you were a little bit distracted when we were asking you, which is understandable. You're on call, right?
Right.
But whenever you answer a question, right, what are you trying to do? Minimize your chances of losing points, correct?
Correct.
So when I say, for example, somebody with a history of pulmonary embolism, no workup, what workup are you going to do? You can easily start by saying, I'm going to do a thrombophilia workup and an
Okay.
antiphospholipid workup. That way
Okay.
you're telling me where you're going with this. And then you can say things that I would include in my thrombophilia workup. And see, I didn't say everything. I just said things that
Correct.
I would include.
Okay.
Okay, would be. That way, if you miss something, the examiner knows what you're thinking. Which
Gotcha.
is
Okay.
generally thrombophilia, antiphospholipid syndrome. Things that I would include in my thrombophilia workup would be protein S, protein C, factor V, antithrombin 3, and then you forget prothrombin. Okay, that's fine. I know it was an error, right?
Right.
But you've mentioned, so it's always a good idea to start with your forest, give them the broad overview of what you're thinking, and then start to hone into the minute details, because there's also a high chance, let's just say, you forgot antithrombin 3 or you can't remember it. But there's
Right.
also a chance that you'll say antiphospholipid syndrome, which includes, beta-2 glycoprotein, anticardiolipin, lupus anticoagulant, and then thrombophilia workup that includes protein S, protein C. All right, doctor, let's go to case number 15.
Gotcha. Okay.
Guess what just happened?
That I was doing okay, so they said go
You
on.
gave them this elegant answer that is indicative that you are going to continue in the same vein. You go,
Right. Okay.
because I didn't know where to go after that, but now I've got them into where I want to go. So it's always start broad, then hone in. They may not ask you all of the questions and so forth. But
Right, okay.
I do think that part of the challenge today was the fact that you are on call and you're probably concentrating on a lot of other things.
Yes, I got 3 in labor.
That's what I'm saying.
Yes.
And then remember, you don't do a Jefferson's incision unless the head is stuck on and trapped on a cervix.
On the cervix.
You delivered the first baby vaginally, it's because the
Cervix is fully dilated.
you would consider doing a Piper's forceps. And the other part of it is,
Okay.
as far as the exam goes, if you didn't say it, you didn't do it. So if you start with, what do you want to show? You want to show them you're a safe doctor. So if you say, I perform all my, that's it. How do you perform even though I told you how do you do a breech extraction, you can always pause and say, before I do a breech extraction, I make sure that I have, watch this, you've got the examiner back. I make sure that I have all the necessary personnel, the equipment, and I'm in the operating room. See, look at that.
Right.
Adequate anesthesia, even though you wouldn't have gotten to this point without all of that. But see how it makes a difference?
Yes. Yes.
You take the examiner back to where you want to go, because you're going to say, you're not going to trick me. I'm telling you right now, I need to be in the OR. I need to have all the necessary personnel, such as anesthesia, NICU, another partner if need be. I'm going to make sure the patient has adequate anesthesia. I'm going to explain to her what I am going to perform. Now, if the examiner doesn't want to hear all of this, they may say, doctor, can you just please tell me the steps of a breech extraction? Fine, fair enough, thank you.
Yes, got it.
But you have told them that I know what I'm doing, and if that was where the question was going, you minimized your chances of missing a point, okay?
Right, okay.
All right, sounds good. All right, let's
Thank you
see.
very much.
And I know you would have done 10 million times better if you were not on call.
I'm hoping that's going to be the case.
You will. It's practice, practice. That's all you need to.
Yes. Yes. Thank you.
All right, sounds good.
Mute myself.
All right, let's see who else is on our nice list of. Right, if your name is on the list, raise your hand. I think I see Dr. Umaya. Is that right? Am I correct? How do you pronounce your name, Doctor?
It's Ume.
Ume.
Can you
All
hear
right,
me?
I am so sorry. I tried my best.
Nope. I'm also on call, but I will do my best.
That's fine.
I just wanted
We've got a theme here, okay? All right, let me find your case list so that we can do this. All right. All right. Okay, doctor, let's go to case number 2.
Okay.
So please talk to me a little bit more about this patient's presentation and story.
Yes, so she presented at 18 weeks and about 3 or 4 days with her cerclage still in situ. She'd had a history indicated cerclage placed earlier in the pregnancy around 12 weeks and had ruptured. With a twin pregnancy, twin A delivered at that shortly after her initial presentation. And she was counseled on the possibility of demise for twin B and also a pre-viable delivery. She wanted expectant management to see if she would make it to a peri-viable or even viable age of gestation. And so 3 or 4 days later, then started to have preterm labor without rupture of membranes. And then I took care, I assumed her care at that time and counseled her on her options. And she decided to remove the cerclage and go ahead with an induction for delivery of the second twin and no longer expectantly managed.
So just walk me through, how was the cerclage still in situ and the first twin came out? That's what I'm trying to understand.
Yes, so she was slightly dilated. So she ruptured and was about 3 centimeters. And at 18 weeks was still able to deliver the first twin. And was no longer contracting for those 2 days before she delivered the second twin.
So do you think that one of the reasons why she delivered was cerclage failure? Because it's highly unlikely that a whole baby would fit through a cerclage that is actually intact.
That is likely. I think that it is possible that between the placement of the cerclage and the time of delivery of the first twin that she did dilate and it was failed. Correct.
Okay, so let's change this case around a little bit and assume that this patient now is 31 weeks.
Okay.
And she is monodi twins. And
Okay.
she comes in with one baby that no longer has a heartbeat or a single twin demise. Tell me what would be your management of that case?
If she was 31 weeks with a twin demise of a monodi pregnancy and there was still a heartbeat for the second twin at 31 weeks, I would counsel her for an immediate cesarean delivery for twin B.
At 31 weeks, you would deliver the other twin.
That is my immediate thought because at that gestational age, it is if twin B is still viable, then I think that the risk of an intrauterine fetal demise of the second twin in a monochorionic pregnancy is greater. And I would want to, in a patient with such a poor obstetric history, even though it is preterm, try to, manage the
So
second.
let's assume, okay, that you decided to keep this patient pregnant, just for argument's sake.
Okay.
And the patient then tells you, doctor, what are the risks or what are some of the complications that may happen to my other baby that is alive? What would you
Yes.
tell them?
I would tell her again that with a demise of the first twin, there is a risk of one, just neurological damage to the second alive twin. Also, the possibility of an IUFD. There is a risk of developing an infection as we expectantly manage. And also,
So can you tell me what is the, what do you call it? Can you please tell me what the risk of a second twin demise and the risk of neurological damage is in this particular case?
yes, so for a monodi pair with demise of the first twin, the risk of demise in the second twin, I don't know exactly the number, but I believe it's somewhere between 10 to 15%.
And what
Of
about the
demise
risk
of
of neurological damage?
And for neurological damage, even higher, probably up to around 20%, but I'm not sure of the number exactly.
I see. Okay, so let's go to case number 16.
Okay,
So this is a patient who had a biophysical of 4 out of 10, is that correct?
that is correct.
And tell me, what is your typical management of a BPP of 4 out of 10 at this gestational age?
So at a gestational age of 38 weeks, with a BPP 4 out of 10, this is a term gestation would be an indication for delivery due to the risk of fetal acidemia and further complications.
Okay, so let's say if this patient was 29 weeks, how would you manage a BPP of 4 out of 10?
If she was 29 weeks, I would counsel her on our findings from the BPP and administer steroids at this time, given the risk of possible preterm delivery within a week. And I would keep her inpatient and repeat the BPP in 12 hours. If the BPP was still less than 6, so 4 out of 10 after the repeat, I would counsel her on the potential risk of both acidemia and fetal demise and for delivery after steroid
So,
administration.
doctor, you don't think a BPP of 4 out of 10 is an indication for delivery straight off the bat?
Not straight off the bat for a preterm gestation. I think after administration of steroids, as long as I would keep her on a continuous monitoring and repeat the BPP in 12 hours.
Okay, so you also try to induce a patient with a BPP of 4 out of 10. Is that typical management?
Yes, because the BPP, the portion of the NST on her biophysical profile was reactive. And with starting Pitocin, there was no further, there wasn't any decelerations. And so I felt that the baby would be able to tolerate labor.
I see. So would there be any instances where you would offer this patient a C-section rather than doing a cesarean delivery? Sorry, were there be any instances where you would offer this patient a C-section rather than attempting a vaginal delivery?
I would offer her a C-section if she failed a contraction stress test. And I thought that the fetus would not be able to tolerate a longer labor process.
I see. Okay. Let's go to case number 18.
Okay.
Can you please define oligohydramnios for me?
Yes, oligohydramnios is an amniotic fluid volume that is less than 5 centimeters for all pockets, and if the maximum vertical pocket is less than 2 centimeters.
Okay, so let's assume this patient came to you in the office at 34 weeks and you found that her fluid was 2.7. Walk me through how you would manage this patient.
Okay, so at 34 weeks with an amniotic fluid, so the MVP is 2.7 or the total fluid is 2.7?
Total fluid is 2.7.
Total fluid. So then I would counsel her that she does meet the criteria for oligohydramnios. I would evaluate by taking a history and noting if she ever felt rupture of membranes, and physical exam, including her blood pressure and cervical exam to note if there's any fluid in the vagina or on Valsalva. And if there is any concern for clinical rupture of membranes. If there isn't, then I would make sure to rule out any other causes of oligohydramnios, including if there are any elevated blood pressures, if there's any concern for bleeding, placental abruption.
Would you manage this patient inpatient or outpatient?
I would manage her as an inpatient.
And when would you deliver her? If oligo persists and fetal heart tracing or fetal testing remains reassuring.
If it remained reassuring, I would deliver her as early as 36 weeks. I would give her steroids and deliver at 36 weeks.
Okay, time. How did you feel you did?
I'm not sure. I feel like I just have unanswered questions after.
Okay, so let's go back. What is the typical management of a BPP of 4 out of 10?
I thought that it was.
So the norm is delivery, correct?
Yes.
Right, that would be the default, right? An 8 or a 10 out of 10 reassuring, you're good. 6 out of 10 is equivocal. If you're above 37 weeks, you may just say, okay, we're going to go ahead and deliver. If you're below 37 weeks, you can go ahead and repeat within 24 hours. A 4 out of 10 is usually an indication for delivery, correct? Now, let me kind of put the caveat, because your answer was not incorrect, because I gave you an extremely early patient, right? So ACOG says a BPP score of 4 usually indicates that delivery is warranted. That's what ACOG says, right? Although at pregnancies at less than 32 weeks of gestation, management should be individualized and extended monitoring may be appropriate.
Okay.
Right?
Yeah.
So you individualized, right? If you had said a 4 out of 10 for me is non-reassuring, I'm going to go ahead and deliver, nobody's faulting you. But you said this is early gestation, I want to give steroids, I'm going to put her on the monitor, I'm going to see what happens. And you should probably add, and I will do this in conjunction with my MFM colleagues, right?
Okay. Yeah.
So you're not wrong, right? You used a different approach than a lot of other people, but that does not mean that what you did is wrong. Does that kind of make sense?
Yeah, that makes sense.
Okay.
That was the unanswered question I had in my mind was,
so like I said, ACOG says a BPP, exactly, this is their wording, a BPP score of 4 usually indicates that delivery is warranted. Although in pregnancies at less than 32 weeks of gestation, management should be individualized and extended monitoring may be appropriate. You chose that route. It's not wrong, because that's your management. And you justified it, right? And I can tell that this was an uncomfortable territory for you, right? Well, it's not, you're not comfortable. Chances are you're probably going to call MFM and say, dude, I've got, this is going on, what am I going to do, right?
Yeah.
And ACOG doesn't give you that option. But if you also feel so uncomfortable when the examiner is asking you, you can say, under these circumstances, I would normally consult my colleagues at MFM. And you know the examiner is going to tell you they're out of town, right? But that's okay. Because what you're telling the examiner is, look, listen, I'm not going to manage this patient alone. I'm going to take the consensus of my MFM colleagues. They'll give you the points for it. Yes, they'll push you to manage it on your own. But you see the difference?
Yes.
So if you feel uncomfortable, just say, under these circumstances, I will usually manage these patients in conjunction with MFM.
Okay.
Ooh, right? Again, you're not going to get away with it. They're going to still
Yeah,
ask
I
you
think
what
for
you're
the
going to do.
exam, I'm always just thinking they're gonna say MFM or any consult is not there, but
Correct,
you're
but you've gotten the points for saying you're going to get the consult.
Yeah.
Right? Because what do they want to make sure that you're a safe doctor and you're not managing? Is a BPP of 4 out of 10 at 28 weeks your typical bread and butter management of OB?
yeah, no.
No. So is it appropriate to get a maternal fetal medicine consult?
It is. Yeah.
Absolutely. Now, I come and I tell you the patient has postpartum hemorrhage, and what medicine are you going to give? And you're going to say, I'm going to consult my colleagues in maternal fetal medicine to tell me that I need to give Cytotec. You probably won't get away with that one, right?
Yeah. Okay.
All right. Sounds good. All right. So that's what I would suggest. If you feel so uncomfortable, say who you're going to consult. They're going to still push you, but at least you've given yourself leeway of not necessarily, but you answered right. That's the bottom line. You individualize, which is not wrong.
Okay.
Right? But I would personally, at 28 weeks, I would say usually warrants delivery. However, if the NST, because she's not in labor, has accelerations and stuff like that, I may put her for extended monitoring, repeat the BPP, and see what happens. And this will be done in conjunction with my colleagues from MFM. And thank you very much. Right?
Yeah. Okay.
All right. Perfect. Sounds good. And you did well considering that you're on call. All right.
Thank you.
All right, let's see who else we have. All right, if you see your name, please raise your hand. So we took Dr. Bing. Dr. Nelson, we may have to come back to you. I just want to make sure that there's nobody ahead of you. Dr. Hawkins, right? I see Dr. Hawkins. Am I right? Dr. Hawkins, you ready?
Yes, I am.
All right. Sounds good. Let's go. And you did submit your case list. There it is. I see it. And I see your OB. All right. Okay, doctor, let's go to case number 7.
Okay.
So I see that this patient is an SMA carrier, correct?
Yes.
So please tell me what counseling you gave this patient and what additional testing did you do, if any?
So when her genetic carrier screen came back that she was a carrier for spinal muscular atrophy, I did bring the patient into the office. We had a discussion about spinal muscular atrophy and the significance in regards to, one, her carrier status and the potential risk for baby, as well as, 2, my recommendation that she also see a genetic counselor as well as have her partner tested as, for carrier status.
Okay, so the patient, after you talk to her about all of this, wants to know what are the baby's chances of getting this disease? What would you tell her?
So I let her know that in the event that dad is also a carrier, there is a 25% risk that the baby could also, but that the baby could have spinal muscular atrophy.
In the event that the father of the baby is not a carrier?
In the event that he is not, then there is still the potential that baby could also be a carrier. But if he is not a carrier as well, then there is no chance that the baby could have the spinal muscular atrophy.
And what would be the chances that the baby would be a carrier, percentage-wise?
There's generally a 50% chance.
Okay. And what is the mode of inheritance of SMA?
Autosomal recessive.
I see. Okay. So let's go to case number 12, please.
Okay.
So tell me, what is your definition of fetal growth restriction?
So it is an estimated fetal weight that is less than the 10th percentile or an abdominal circumference less than the 10th percentile.
Okay. So in this case, right, when did you diagnose the fetal growth restriction?
And I'm trying to remember. I was just thinking about that as I'm looking at it. I don't have it listed. I honestly can't remember if this was somebody who it was later in the pregnancy or whether it was earlier within the pregnancy. I'm sorry.
Okay, so please tell me, at what gestational age do you normally recommend delivery of fetal growth restriction?
So it depends upon the severity of the growth restriction. Generally, if it is somebody who is less than the 5th percentile, then we have done as early as 37 to 37 and 6. And then if it's somebody who is in between the 5th and the 10th percentile, we've done 38 to 38 and 6. And then if it's somebody in the 10th percentile, we also still consider doing the 38 to 38 and 6.
And Dr. Do Dopplers play a role in your timing of delivery?
Yes. That also is another factor. And so if the Dopplers are normal and the growth restriction again falls between that 5 to 10th percentile, then we'll do 38 to 38 and 6. But then if there is reversal, then we'll consider doing earlier, generally somewhere between about 36 to 37, if it's noted around that time.
So you
And
would
then
wait-
for,
if there is reversal, you will wait till 36 weeks?
sorry, not reversal, I meant absence, excuse me.
So for absence, you would
Reversal.
wait for 36 weeks. So then tell me, how would your management of fetal growth restriction differ if the baby was less than the 3rd percentile versus between the 3rd and the 5th percentile?
So for those babies, I mean, really for all babies that are growth restricted, we're going to do serial growth scans every 4 weeks. And then we start our Doppler, umbilical artery Doppler assessment weekly at the 32-week mark. Generally for those smaller babies, if there is concern as well for abnormal Dopplers, then considering how far along the patient is within the pregnancy, we do consider inpatient management from there, continuous fetal monitoring with steroids, and then make plan for delivery if there is worsening of the Dopplers in a less than 3rd percentile baby.
I see. Do you guys utilize the ductus venosus in any way in your management of fetal growth restriction?
No.
Okay. So talk to me about this case 16, please.
Okay. So let's
So tell me more about this patient.
Okay. I'm just reading back through. We said 16, 25 weeks and 2 days. Yes, I remember this patient. So this patient had come in earlier in her pregnancy and at that time was noted to have a shortened cervix. It was less than 2.5 millimeters. And we had gotten maternal fetal specialists involved very early on. We had counseled her about cerclage versus vaginal progesterone, and she had desired to do the vaginal progesterone, but then had come
So
into the
you offered her a cerclage at a cervical length less than 2.5?
Yes,
Does this person have a history of prior preterm birth?
she did. Mhm.
I see.
And I'm just realizing I didn't even put that. Oh gosh. But yes, she did.
Okay, and she declined the cerclage?
She declined the cerclage, but she was amendable to doing vaginal progesterone. However, by the time that she had presented into the hospital, she did inform us that she had not been compliant with the vaginal progesterone and has had sexual intercourse within about 24 hours of presentation, but came in with report of vaginal bleeding, concern for leakage of fluid, and was feeling regularly occurring lower abdominal pain.
Okay, so please tell me here, even though you had concern for choreo abruption, you gave this patient precardia?
Yes, I did.
Even with the choreo?
Sorry. So when she initially came in, there was no concern for choreo. The choreo was something that eventually developed over time after she had been ruptured for several days. When she initially came in, just the vaginal bleeding and the leakage of fluid was the primary concern. And so, yes, there was concern potentially for abruption. And I do realize now that precardia probably was not the best idea, but she was also stable from a bleeding standpoint and clinically did not give me any
Okay,
hot.
let me stop you here for a second.
Mhm.
Don't give the examiners any ammunition,
Right.
okay? Even if you think it's not a great idea at all. Now, you absolutely don't make up stuff,
Mhm.
but can you put your ducks in a row where this becomes a much more defendable scenario,
Yeah.
right? The answer is what? She's 25 weeks into.
Mhm.
Is it really, really? So first of all, do we, under normal circumstances, tocilize PPROM?
No,
No,
because there's always that potential concern for infection.
that's fine. So when do we tocilize PPROM, or when would we possibly tocilize PPROM patients?
In an attempt to try to get antenatal corticosteroids on board, or if it's somebody who you're trying to transfer to a
Perfect.
higher level of care center.
So stick to that, right? And
Okay.
that would be a story that you would tell, right? And then you've got to make sure that when you say, and when we found, like, so first of all, this is a patient with a prior preterm birth. So truly, right, at 2.5 centimeters and less, she should have been offered a cerclage, which she was, and she declined. She accepted vaginal progesterone. She was not compliant. She came in preterm labor, right? You
Mhm.
can't force people to get procedures. You can only counsel them, tell them, let them know, right?
Yeah.
Then she came in, and you can say, because the patient was extremely premature, in an effort to bridge her through her steroid window, we gave her tocolysis. However, as soon as the patient started to exhibit signs and symptoms of infection and choreo, we aborted our tocolytic attempt and we went ahead and delivered. Correct?
That
Now, you
sounds
may
so.
not word it the same way that I did, but that's the message that you want to convey.
Yeah, I think that's one of the biggest things that I need to work on too, is just being able to convey and formulate it in a way where, one, it's not like I'm rambling, but then two, like you said, it's not like I'm giving them ammunition to just go and say, okay, well then
But
why'd you do this? Why'd you do
Never
that?
say, oh God, I think looking at this is not the greatest of ideas, because they're gonna enjoy that. And the last
Exactly.
thing you want them to do is say, oh really, you didn't think it was, so why did you give it at that time? Why, whatever, what
Right.
made you think it's a good idea? It's in your case, and your job is to what? Defend your
Defend my
case
case
list,
list. Mhm.
right? Now, there are certain times where I would tell you, no, don't defend that. Own up to it, okay? Let's just make up some stuff here that is not on your case list. But let's say, okay, you managed PPROM and you said latency antibiotics and you put next to it tetracycline, right?
Right.
I'm just making up stuff. I know you didn't do that. And they tell you, why did you give tetracycline for PPROM? Is there any way you can defend that?
Mm-mm. No.
You can't, right? It's on your case list. You wish it wasn't, but it's there. And in this scenario, that would be the safest bet, would be to say, at that point in time, I was under the impression that tetracycline was the correct management of PPROM. However, I have since, learned that it isn't. I have changed my practices, and now I give this. Thank you very much, because it's blatantly wrong. There's no way you can convince anybody that tetracycline is a treatment of PPROM, right?
Mm-hmm.
Right. But you're not in that scenario. You're in a scenario that is acceptable. Is it acceptable to give tocolytics for a PPROM patient very early in gestation? The answer is absolutely yes.
Yeah.
How can I justify it? To give betamethasone. So can I say, Now you gave two tocolytics, but you can argue that the magnesium was solely for the neuroprotection and the Procardia was for the
The tocolysis.
policies, right? And take it from there. Now, I'm going to say your gestational ages for fetal growth restriction were not correct, and neither was
Okay.
your 5% cutoff. Remember, we use 3% and 10%. Third percentile and the 10th percentile.
10%.
So-
Okay.
Okay, so if we go here, right, I'm going to urge you to do the following, right?
Mm-hmm.
So if you actually go to SMFM, FGR, right? And this is endorsed by the American College, so you're actually not doing anything, what you call it, you're not doing anything that is not ACOG thing. And if you go to the original article here, and I urge all of you to actually look at this and go to it and make sure that you have it all committed, they actually have a nice little flow chart, all right? For those of you that are not familiar with this nice publication, it's actually beautiful. It has there. See that? I made it bigger and then I made the flow chart disappear. Is that what I did? Okay. See that here? Fetal growth restriction, it gives you the definition, right? And it tells you what to do, but then it also tells you the definition of severe, right?
Mm-hmm.
And then it tells you that if we have Dopplers, it even tells you how frequently that you do the Dopplers, how frequently you do the EFW, every 3 weeks, every 2 weeks, deliver at 38 to 39, deliver at 37, deliver at 33, and so forth. Do you see that?
Mm-hmm.
I would urge you to commit that to memory when you're managing fetal growth restriction. But remember, fetal growth restriction, right? Less than the third, less than the third.
Less than the third.
Here it is. Third above third. That's the distinction. All right. So I try and give you guys, you know, when we get something important like this, I try and give you one source that nobody can argue with, that is very sound. All right. Perfect. I hope this helped you, Dr. Hawkins.
Yeah, thank you so much.
All right. Perfect. All right. Now, let's see. Who else on our... I think we're going to go with Dr. Nelson, because I don't see anybody that is above, right? Am I missing anybody, or is it Dr. Nelson that should go? Let's see. If you think that you're ahead of Dr. Nelson, please raise your hand. Oh, there it is. Dr. Tiffany, right? Tiffany, I see your hand. You're ahead of Dr. Nelson. Is that correct?
Yes.
Are you ready?
Yes.
Okay. You're never ready. Nobody's ever ready, right?
Yeah.
All right, let's get your case list and wrap it up here, okay? And you did submit your case list, correct?
Yes. I submitted it. Oh, there it is.
There it is. I see it. Okay. Now, what do you guys notice, right? There's a lot of repetition in your case lists, right? There's a lot of same stuff, which means the examiners are going to ask you about the bread and butter of these case lists. You've got to make sure that you know them, right? Okay, doctor, let's go to case number 47.
Okay.
So tell me, what is your management of a patient with a marginal cord insertion? How would your management differ during pregnancy with a marginal cord insertion?
For patients who have marginal cord insertions, I typically do serial growth sonogram starting at 28 weeks. That's really the main thing that I do that kind of changes things, or my different plan of care for these patients.
Okay, would you enroll them in antenatal testing?
No, I would not.
At all? So you don't think a marginal cord insertion has an increased risk of an IUFD? Okay, I see. Would that change if I told you that she had a velamentous cord insertion?
Yes.
So would you enroll them in testing with a velamentous cord insertion?
Yes, I would.
Okay, what is the definition of a velamentous cord insertion?
A velamentous cord insertion, it occurs when the vessels of the umbilical cord are exposed as they're traversing or connecting to the placenta.
How is that different from a vasoprevia?
A vasoprevia is when it is traversing over the cervix or the internal os.
Okay, is there anything else that would give you a vasoprevia other than a velamentous cord insertion on top of the cervix?
I believe if you have a I believe if you have a succentrate lobe of your placenta, that does increase the risk of you having a vasoprevia.
What would be the definition if you have a subcentrate lobe or a bilobe placenta? Would all of them give you a vasoprevia, or how would you diagnose a vasoprevia in these scenarios?
I believe in these patients, I don't think it's every single patient who has that, but as the pregnancy is progressing and the placenta is traversing up the uterus as it grows.
Okay, so let's assume this patient has a vasoprevia. What would be your management during pregnancy for this patient?
So if the patient had a vasoprevia, I would admit the patient at 32 to 34 weeks, because I wouldn't want them to go into labor, because there's a risk of a fetal risk if they were to go into labor with the vessels traversing the cervical os. So they would get antenatal testing. I would consult MFEM, and they would be in-house.
Anything else you would like to give?
To give. Not that I can recall at this time.
Okay. You wouldn't consider giving them steroids at any given time during the pregnancy?
Yes, I would give them steroids.
At what gestational age do you think it's appropriate?
I would give them steroids at 35 to 36 weeks during that time.
I see. And you'd keep them pregnant till 36 weeks with a vasoprevia?
I would, honestly, I would have to check to see when the recommended delivery would be for vasoprevia.
Okay, so let's go to case number 55.
Okay.
So this is a patient that has in vitro fertilization, correct?
Yes.
When you saw this patient for her first prenatal visit, what did you counsel her she was at an increased risk of because of her IVF pregnancy?
I counseled her that she was at an increased risk of preterm labor and preterm birth. She was also at an increased risk of placental abnormalities. Those are some of the things that I counseled her that she was at increased risk of.
Would you enroll this patient in antenatal testing?
Yes, I would give her antenatal testing.
So you did not counsel this patient that she's at an increased risk of IUFD?
She isn't at that's something I apologize. She's at increased with IUFD.
I see. Okay. Do you think she's at an increased risk of having fetal cardiac malformations? And if so, would you offer them a fetal echo?
Yes, I would give her fetal echo. She's also at an increased risk of hypertensive disorders in pregnancy.
I see. Okay. So can you please give me the definition of gestational hypertension?
Gestational hypertension is a hypertensive disorder of pregnancy that occurs in patients after 20 weeks when they have mild range blood pressures greater than 140 over 90, greater than 4 hours apart. You also have evidence of proteinuria.
With gestational hypertension?
Oh, I apologize. You do not have evidence of proteinuria with gestational hypertension.
I see. So let's say this patient that is with gestational hypertension, correct? Let's assume she is 31 weeks.
Okay.
And she comes into the office and you have made the diagnosis of gestational hypertensive previously, and you're doing your serial surveillance for this gestational hypertension. And she comes in and she goes, since yesterday, I have been complaining of epigastric pain and a headache. Please tell me how you would proceed with the management of such a presentation.
Okay, with this patient, I would then do a history, trying to get more information if she's tried to use any kind of medication to cure her headache. I would also assess if her epigastric pain, if is it migrating or does it seem like it's more along her right side?
I tried Tylenol, and I tried, my husband at home has Percocet. I took a tablet of that. And just for good measures, I also took ibuprofen. And my headache is a 9 out of 10. It's pounding. It has not gone away. I tried all the antacids on earth, and my epigastric pain is still there. How would you proceed with such a presentation?
With that information, I would then be concerned that we are now progressing to preeclampsia with severe features, given that the unrelenting headache and possible right upper quadrant pain or epigastric pain is present. So at that time, I would then check the patient's blood pressure, and then I would get preeclampsia labs. And given we have concern for preeclampsia with severe features at 31 weeks, I would also admit the patient. I would also consult MFM at that time. I would start the patient on magnesium. I would administer steroids.
Do you think that would be an indication for you to proceed with delivery?
At 31 weeks, no, I would try to see if I can, with the administration of the magnesium as well as getting steroids on board, see if I can help control that way. And then if we are unable to control it and her symptoms are persistent, then at that time I would, with the help of my MFM colleagues, we may be able to proceed with delivery.
Perfect. Time. All right. How did you feel you did?
I think I forgot some things. I needed some prompting.
Yes. So I think you did well with the gestational hypertension, right? So gestational hypertension, as soon as you get headache, preeclampsia, unrelenting, unresolving, then you've moved with preeclampsia with severe features. Delivery is warranted at that point in time because you're no longer a candidate for conservative management. But if the patient, you've got to stress, but if the patient is stable, labs are good, blood pressures are okay, I will try to administer steroids and magnesium and all that sort of stuff, right? So here I don't have a lot of concerns. I don't think you liked my question about vasoprevia a lot.
Yes, I need to read about
Okay,
that.
so let me kind of so I can make sure that we don't get anything out of this that is incorrect.
Okay.
You were correct 100% that marginal cord insertion does not need antenatal testing.
Okay.
As much as I tried to say, are you sure? Do you want to do this? Do you want to do that? You're like, nope, I don't. I just want to do serial growth ultrasounds. And that is absolutely correct. But now when we change it to velamentous, right, then you do need antenatal testing.
Yeah.
So what is the difference between velamentous cord insertion and a vasoprevia? The velamentous cord insertion is how the cord goes into the placenta,
Mhm.
right? And the vasoprevia is related to, if we have a velamentous cord insertion, where is it in relation to the cervix, right?
Mhm.
So as long as the velamentous cord insertion is not within 2 centimeters of the cervix, is not a vasoprevia. So then
Okay.
what's a vasoprevia? It is a velamentous cord insertion that is within 2 centimeters proximity to the cervical canal, right?
Mhm.
And then what else can make you a vasoprevia? It's a bilobed placenta or a succinturate lobe where the connecting vessel, again, is within 2 centimeters of the internal cervical canal. That's all it is. Then your management, you weren't way off, right? But they tell you to consider hospitalization with vasoprevia when, right? Between 30 to 34 weeks. That's when you should consider hospitalization. And you should offer them steroids somewhere between 28 to 32 weeks, depending on depending on what you want to, what you see her risks are. And then delivery, it's not wrong to deliver at 36 weeks. You can deliver anywhere between 34 to 37 weeks by C-section.
Okay.
Okay, so that's kind of that. Vasoprevia is not an easy topic. It's not necessarily under the realms of general OB management, but I kind of prompted you in that direction. And you can always say, you're never wrong by saying, I'll manage my vasoprevia in conjunction with my maternal fetal medicine colleagues, right? But what is your goal? To prevent this patient from going into labor, right? That's your whole goal. Or to deliver her before she goes into labor, hence the delivery between 34 to 37 weeks. She's at an increased risk of delivering early, so she needs steroids. She's at an increased risk of bleeding and things going sour very quickly, so you do that as an inpatient management at some point in your pregnancy, correct? And if they tell you, well, what determines admission at this gestational age versus this gestational age, you can say how close the patient lives to the hospital, patient
Mic on.
reliability, patient symptom,
Mic off.
prior obstetrical history. You can even throw in fetal fibronectin and cervical length, which is one way of managing these things and so forth. All right.
Mhm.
Do you have any questions about what we talked about?
On the actual test, like
Mhm.
for like counseling for the IVF patient, if
Yeah.
I don't say all the things, will they actually prompt you, or will we just move on?
It depends on the examiner, and it depends on what what they're trying to get and where they're trying to lead you.
Okay.
So of course, what is the ideal? You get everything right without them prompting you, but it depends where they want to go, right? It depends what they're trying to achieve. And it also depends on how well you're doing on the exam, and if the examiner just thinks that you've forgotten it because of pure I'm tense, right? Because here's the deal. If I prompt you and you say, oh yeah, that, and you give me the answer, that means my hunch in you knowing it, but I just feel that you're anxious in the exam, and I'm just trying to, so the overwhelming majority of the examiners are actually very nice people that are not trying to fail you. They're really trying to test you to see if you have knowledge or not. So if they can see and they understand that this is a very tense-inducing scenario, you're very tense. So some of them will try and calm you down and relax you to just see if it's truly a lack of knowledge or it's just the situation of, I am not comfortable here. So you can get either or of the examiners. They can prompt you. They may not. They may just stay quiet. And there are some examiners that, I kid you not, will just go, I see. I see. anything else? Are you sure? And that will be all what you will hear from them. And I kid you not, there are some situations where they'll ask you, what is your name? And you'll say it, and they'll look at you and go, are you sure? And you'll look at them and go, I don't know. I don't even know if that's my name anymore, right?
Yeah.
But that's when you say yes, okay? Now, there are some scenarios where the examiner will say, you're wrong. What do you do in such a scenario? Okay, so let's say, let's do, and I apologize, I've gone a little bit over time, but I think it's important what we're talking about. Let's say if you say, what is the treatment of GBS? And you say penicillin, right? Which is a true answer, and the examiner goes, you're wrong. How would you maneuver yourself in such a situation? And you know you're right.
Yeah. I mean, I would say in my practice, this is what we use. I don't know.
Okay, so one good way of getting out of this is, Dr. So-and-so, I do have a lot of respect for your opinion, right? Perfect. However, at this point in time, this is what I recall as the correct answer. Thank you. Do you want to change your mind? No, I don't. So you've left some leeway. I have a lot of respect for your opinion. I'm sticking to my guns, but I'm leaving myself some leeway just in case I'm wrong. This is what I recall as the correct answer at this point in time, but I'm not changing my mind on this. Right? So, because if you say, okay, the worst scenario is you say, no, you are wrong, right? That's confrontational. And God forbid if you were actually not right, oh boy, that's not going to go well at all, right?
Yeah.
Perfect. Good. So it's these little things that can make the examiners, but some examiners will help you more than others. Some, some examiners will be, it's just the way it is. I had, my exam, one of the examiners was super nice, super helpful, and the other one was not. You just have to deal with whatever's there, right?
Okay, that's perfect. Thank you.
All right, sounds good. I hope you guys are finding these webinars very, very helpful. And I hope that you're finding our years of experience and the tips that we give you guys coming from multiple. And I can't tell you the number of people that have taken, mock orals and things like that and have called me immediately after the exam and like, you are more tough. I'm like, thank you. That's actually a compliment, because if I was more tough, that means I either prepped you very well to make your exam feel well, or you had practiced so much that you've gotten so used to it that the exam is no longer a problem. All right. Okay, everybody, I will see you soon.